Okay, so we are going to talk about tumor ablation for vertebral augmentation, kyphoplasty, and tumor ablation. So during this session, what we're going to do is we're going to have a demonstration with a chicken breast right here for tumor ablation. And this model is going to run for about 15 minutes. And so we're going to turn this on presently. And this is a vertebral body that is overlying the chicken breast with the osteocool needles in place. And what this will do, this will demonstrate within the confines and slightly outside the vertebral body the ablation zones of the osteocool needles. So this is a bilateral access, either bilateral transpedicular or bilateral perpendicular access to the vertebral body. We will ablate this, so we will go ahead and turn this on. I'm going to demonstrate this in a live patient, but the ablation will happen here. Then I'll put the needles in to show you exactly what this looks like inside the vertebral body. And then while we're doing this, I'm going to show you all 3, maybe 4 access techniques to the vertebral body. So the transpedicular, perpendicular, extrapedicular, modified inferior plate extrapedicular approach, and maybe the en-face view if we don't have an en-face time in the interim. So we will go ahead and start the ablation, and this is going to ablate, give us a nice demonstration, the ablation zones in the chicken breast. All right, so we will access transpedicular approach. So the start is centimeter up, 2 centimeters out. And we will access using the beveled needle. So this is a beveled needle. It has a single directional bevel. The arrow on the tip indicates the direction of the needle. There we go, the direction the needle will go. And we have a bibeveled needle that has a bevel on each side, and this will tend to go away from the face of the bevel. And we have a tri-beveled needle that has 3 beveled surfaces that's useful for accessing the needle. The trick about unidirectional single needle is if you have the bevel, the flat surface, against the convex surface of the vertebral body, it can slip off. Easily remedied by turning the needle around, so you get the point that goes into the vertebral body. And so we always use a mallet for this. For those of you who are not using a mallet for your augmentation, use a mallet, because that's definitely what is necessary. You have better control. And for people that think they have good control without using a mallet, it only takes 1 plunge to make you a believer. So 10 o'clock and 2 o'clock positions, right? This is 2 o'clock position of the vertebral body. And this is a transpedicular approach. The 10 o'clock approach is on the other side. And we will take the face of the needle is facing opposite me, and we're driving the needle in this transpedicular approach. And we will drive it down to the pedicle. And before we transgress the medial wall of that pedicle, we're going to look lateral. So before we transgress the medial wall of this pedicle, we're going to look lateral, make sure we're in the posterior portion of the vertebral body.
And Doug, for reasons for the audience to help educate them on reasons why is that you not want to transgress the medial wall of the pedicle before entering the vertebral body?
So we want to stay away from the spinal canal. And this is easily within the vertebral body here. I'm going to make a little bit of trajectory correction. I'm going to pull it back to the posterior portion of the vertebral body, the posterior wall. And so if you don't transgress the medial wall of the pedicle before you get into the posterior portion of the vertebral body, you know you're away from the spinal canal. And so I'm going to make a trajectory correction by pushing it over this way, keeping in mind that the direction of this needle will go this way, toward me and into the vertebral body. I'm also going to go a little bit inferior. And we can make good trajectory corrections on this. And I'm going to take this into about this direction. I'm going to use the drill to drill out the anterior portion, 3 to 5 millimeters from the anterior portion of the vertebral body. Here's the drill, and I'm going to just use intermittent fluoro. Most of the time, people use live fluoro, but just to save radiation, I'm going to use intermittent fluoro. So within 3 to 5 millimeters of the anterior vertebral body, I'm going to come back around, and I'm going to use the same beveled needle on the other side. So we'll come back around to AP.
So you're using that drill device to create a cavity and obtain some room for the balloon, correct?
So once the drill is drilled out to the front portion of the vertebral body, we have room for the balloon. And on radiofrequency ablation, we will ablate first, and then balloon kyphoplasty second. So in this one, we'll take a similar approach, but 10 o'clock position, of course, because it's the opposite side. And we're going to do the same thing here. I'm going to show you a little trick whenever we come up to the medial portion, medial border.
Does everyone see that?
The pedicle, and you're concerned about it. Let's say, hypothetically, we switch to the lateral portion, and we're not quite past the canal to the posterior border of the vertebral body. And what we can do is we can just turn the direction toward me, the tip, and the bevel alteration of this will give you a few more millimeters. So keep in mind the distal tip of the needle here, and then we'll shoot it after turning the bevel, and it gives you a few more millimeters of access. So we'll go ahead and switch lateral. And that's a good tip and trick if you are not quite crossing the posterior border of the vertebral body. And so we are in good position. We're going to go ahead and take this out. I'll pull it back just a hair. And we'll use the drill to drill within 3 to 5 millimeters of the posterior vertebral wall. And right about there is the final resting position. So while we're ablating, so I think we can probably see the ablation zones of the needle still running. And the ablation zones are elliptical, and they join in the center. And they will continue to expand to encompass the whole of the vertebral body. Let's go ahead and let's come back around to AP. So this is a transpedicular approach. I'm going to steal one of the cannulas to demonstrate. I'll reaccess that when we are ready to do some ballooning and cementing. So I'm going to show you a different approach. So peripedicular access.
And when do you find you use the peripedicular process?
So peripedicular access is fast. It accesses at the body, come inferior just a little bit. Body pedicle junction. And we're on a line from ipsilateral superior to contralateral inferior vertebral corner on this line. And we're going to go one vertebral body width out along this line. So about right there. So we're aligned for ipsilateral superior to contralateral inferior vertebral body. We're going to go one vertebral body width out, and that's going to be our start point. One vertebral body width out, and this is going to be our start point here. So if we look, this is just slightly farther out than our transpedicular approach. So this is the same exact trajectory. So what this is, you'll note we were a centimeter up, 2 centimeters out for the transpedicular approach at the 2 o'clock position of this pedicle on the patient's right. And what this is along the same trajectory, just farther out. So we're going to come down, and you can either do this in the en face view, or you can do it in the AP view, and we're going to feel osseous. And then we're going to go ipsilateral about 30 degrees. We're going to make sure we're in the right approach. And if you want to do this all en face or in the 20 to 30 degree ipsilateral oblique, that's perfectly fine. So what we see here, if we could drop it, move towards you just a little bit. So the needle position is just anterior to the pedicle. This is a parapedicular approach. It's above the equator, the mid portion of the pedicle, and the junction between the pedicle and the body will be the entry zone of this needle. So because it's outside of the pedicle, let's come back around AP, you don't have to worry about fracturing off the pedicle whenever you put a lever arm it. So we're in the right position. I'm going to access the vertebral body. Okay. And before we transgress the medial wall of the pedicle, we're going to take a look lateral and make sure we're in the vertebral body. You'll see the start point in this is farther out than the transpedicular start point, and it's also a flatter trajectory in the needle, a flatter angle on the needle. And so we are in the posterior portion of the vertebral body. What I'm going to do is that we're going to use this to try to target the center portion of the vertebral body. The transpedicular approach, you'll see, I'll put the needle back in, and we're going to use this to target more of the center of the vertebral body. So we're kind of right in the middle, and we're going to come back around and take an AP shot, and we'll see the difference between the transpedicular approach and the parapedicular approach. So this way, we're more toward the center of the vertebral body, almost dead center. We could just give it a couple more taps. To put it in the center portion of the vertebral body. And this is the transpedicular approach. Above it sits quite a bit more ipsilateral. So transpedicular, parapedicular. So let me demonstrate one more. So I'll use the same vertebral body. That's nicely lined up. So we're going to go 45 degrees toward you. So this is called the inferior end-plate approach, the modified inferior end-plate extrapedicular approach. Okay, so our start point will be, I'm going to go just a little bit inferior to that, about right there. So our start point is just above the inferior end plate at 45 degrees. We are going anterior to the pedicle, posterior to big red and big blue, just above the inferior end plate, just below the midpoint, because that's where the radicular artery sits. So this is our start point for the inferior end plate approach. And this is done down the barrel of the needle. So just get it under the skin, and you can target it from this. The thing that is different in this cadaver from a real person is we're outside the multifidus muscle with this approach. See how lateral this is? This is a very far lateral approach. And we are outside the multifidus muscle. So typically you'll need to have a Kelly or Coker clamp of some kind to hold it in place. And this is the appropriate target, right about there. So what we want to do is we want to have it just above the inferior end plate, just anterior to the pedicle, and below the segmental artery, and posterior to the great vessels. And so we'll have a start point here, and you can see what kind of flat trajectory we can have on the needle. I feel osseous already, so I'd like to come back directly AP, and we'll take a look at it. This is, if this looks odd to you, this is a pretty typical approach. This is a fairly typical way, easy way to access the center of the vertebral body. So let's drive it on in. And we'll park it right about close to midline there, and we'll take a lateral view. The advantage of the extrapedicular approach. So I was talking to Dr. Brian Rich, who said he's going to use this because this is an advantage for patients with hardware. And there's a common belief that sometimes you can get around hardware, and this is just short of midline, so we're almost dead midline. We'll put the finishing touches on it, make it perfect. So it should be in the midline on AP, which almost certainly it is, mid to anterior portion of the vertebral body in the lateral view. This is designed for things like severe vertebral plana, where you can't access it from a top-down approach, from a 10 o'clock and 2 o'clock transpedicular approach. It's designed for hardware is the biggest advantage, and for getting around a tumor. So hardware, when you have a big 5565 screw in the pedicle, and you can't get around it using a perpendicular approach that I just demonstrated to you that was around the pedicle because of the size of the screw is too big, this is a perfect approach for it. So I don't know how many of you guys do all three approaches. I'm not good enough to use a single approach. I have to use all three approaches to get into the vertebral body. People say, well, I use transpedicular approach, that's what I do. There will be a time you won't be able to use transpedicular approach. The three scenarios I just described to you are the common times where you can't use a transpedicular approach. But this has been published previously, as has the perpendicular approach. 96 consecutive patients, no complications, and the pain reduction scores are typical of vertebral augmentation in general. So we have completed our ablation procedure. I want to do one more approach, and then I will re-access transpedicular that approach, and we will do the balloon kyphoplasty on that side. So just leave it about 30 degrees towards you.
Doug, would you agree that in the transpedicular approach, you'll have to go on both sides by bipendicular approach?
Yes, absolutely. It's very difficult to get it in the center of the vertebral body using a classic transpedicular approach. The perpendicular approach and the extrapedicular approach are used to really target the center of the vertebral body to a unilateral approach. The best method to reestablish height for height reduction is a bilateral approach. So if you guys are happy and pleasantly pleased with your bilateral access, that is absolutely typical. That's the best way to reduce height and to establish the best distribution of cement throughout the vertebral body. And the appropriate distribution of cement is end plate to end plate between the pedicles. And until you've done that, you haven't completed your augmentation kyphoplasty. So this is an en face approach. So we'll just come down, this is looking straight down the barrel of the pedicle, and we just mine the medial wall, and we just keep going until we're in the posterior portion of the vertebral body, not to transgress the medial wall of the pedicle. And we will go until it feels like we're in the posterior portion of the vertebral body. And we'll look lateral. And this is called the en face approach, or the gun barrel approach, or down the pedicle, straight down the pedicle approach. So we're in the posterior portion of the vertebral body, easy enough. So we'll come back around to AP. I'm going to re-access the level that we have at the transperpendicular approach. Go through the same access point. Great. All right. And again, we will make sure to mind our landmarks, not to cross the medial border of the pedicle until we're in the posterior portion of the vertebral body. And let's check that laterally. We'll make sure. So we always do the ablation first, and we've done the ablation with the chicken model, and you can see it encompasses the vast majority of that vertebral body. But once we access, we're in good position here. I will.
Can we get another lateral? It seems the photo.
Yeah, let me reshoot that. It's dark. I will, before I drill, if you're dealing with a tumor, the thing that you want to do is do a biopsy. And so this is a biopsy needle. This is a Francine type tip. It's bibeveled and it has tines on the end. And this is what it looks like whenever you go in to do a biopsy. And you'll just advance it similar to a drill. And this is a very nice cutting device. You can feel the bone being taken up. And so we'll have the biopsy cannula, and the stylet will push out the biopsy, and there it is. So I always want to take a biopsy when dealing with the tumor case. So, or an infection. The old biopsy all infections and culture all tumors. And I meant to say it like that because they're very difficult to distinguish one from the another quite often. So I'll drill all the way out to the anterior portion of the vertebral body, and I will put the tumor ablation needles in so you can see it. Just want to put these in. This is the same thing we used in the ablation here. And it just fits over the top of that with two of the appropriate sized ablation needles, and use that. You base it, it's color coded based on how big this is. And then we will place these in the appropriate position. No, we'll just. Okay. So, very symmetric. Pull the cannula back on this. And then we're ready for the burn that we just demonstrated here. Okay, fast forward, not to take another 15 minutes for the ablation. You always want to ablate first because there's some evidence. Karen Murphy did a nice paper in animals that showed if you inflate the balloon or inject anything into the vertebral body, you can get tumor cells circulating throughout the vascular system. The other paper by Cruz, that if you balloon prior to doing an ablation, it has the potential to spread tumor within the vertebral body. So, completed, done, and we will balloon on both sides. Yeah, mix it up. So we're going to mix some Expeed cement. This is quick-to-dose cement. So the balloon will go in. It has marker bands on the proximal and distal portion of the balloon. You can see this pretty easily. Very nice.
Sorry, Doug, to go back to the question for the ablation, how far beyond the proximal marker does the ablation take place?
So I'm going to direct our attention back to the chicken breast. So here is the distal tip and then the proximal tip, and this is kind of the center of this big elliptical lesion. So this provides a nice large burn. It provides a burn elliptically around the needle on both sides, but what you'll see is with 2 needles in place, using a bilateral transpedicular approach, you get this nice big oval of ablation. So the ablation zone mimics the shape of a vertebral body, the tuna can shape of the vertebral body. So this is the ablation zone has each independent ablation zone and then an amalgam that will ablate tumor thermally. So we will inflate the balloons, keeping an eye on not only visual, but also pressure. These are expander 2 balloons. They're pressure rated to 700 PSI. Low compliance, they're made of nylon. These will routinely go up to 1,000 PSI. So if you want to really test them, you absolutely can.
And for our audience, Doug, how high do you go?
So functionally, I will take these. I don't mind the pressure or the volume. I do it all by position within the vertebral body and height reduction. So for this, because it's a tumor ablation case, we want to get the cement in the center portion of the vertebral body, in plate to in plate. And so we'll take a AP view with the balloons in place. So that's a good lateral view, and we'll make sure we're in the right spot on the AP view. So very nice, right? We could probably even bring the opposite balloon up a little bit. And both balloons up a bit. So once we do this, appropriate amount, very nice, we will now inject some cement. And these, you can either deflate the balloons by counterclockwise motion or by triggering it. And this brings it down very fast. Balloons out. And cement. So I'm going to demonstrate the CDS, the cement delivery system, is done by gun. This is Speed with saline behind the cement and the plunger. This will be done in a coaxial method. And this is designed to deliver the cement. Let's go ahead and look lateral, if you would. Take that out of your way. This is designed for the gun to be delivered outside the beam so you can stand away while you're delivering it. And repetitive triggering this will build up pressure. Thank you. So build up a little pressure, and this is the quick release valve that you can access using your thumb. Perfect. So be able to cement nicely. And always keep in mind that you have to have something on the other side or it will come out the other needle. All right. Go to the other side. And we'll have to use the double shadow of the cement to be able to see it. So we can see one set of the cement on the other side through the first cement. All right.
And how much are you looking to put in?
So commonly I'll put in about 5 to 8 cc's in a lumbar vertebral body. One of the errors that people make the most is not putting enough cement in. And this is a swing back AP. It looks very nice on lateral view. We'll take an AP shot. So on an average, at least 4 to 6 cc's per lumbar vertebral body, 3 to 5 cc's for a thoracic vertebral body. And these are just generalizations. These are just general rules. Very nice. Got a little bit of extravasation out the opposite side, but that is perfectly fine. So cement extravasation happens, the evolved trial 21.7% of the time. This is the most common type of extravasation out the side. Number of serious adverse events or SAEs, 0 from the entire trial of 354 patients. And so,
Like in instances where the extravasation, when should you worry when the extravasation?
so extravasation, whenever it comes posteriorly, is the only time you really have to worry about it. And I'm going to put just a little bit more. Yeah, we have some more cement. So the only time you really have to worry about it is when the cement extravasates posteriorly or into the neural foramina. So cement extravasation is very common. The evolved trial, 354 patients, extravasation rate of between 21 and 22%. But there's also reports cement extravasation rates in vertebroplasty up to 63%,
Right.
even more. And it's quite common. It's just, you just don't want extravasation in the wrong spots. The error I think people make is not putting enough cement. So the Swiss registry data says that, let's go lateral, please, that the single thing, modifiable thing that you can do to improve pain and have persistently good pain relief is to inject more cement. And that their recommendation was at least 4.5 to 5.5 cc's. That was a paper by Roeder. So, very nice. All right. Always inject in the lateral so you can watch for posterior migration. Okay, come back around to AP.
And for our audience, Doug, when it extravasates into the disc, are you worried?
Say that one more time, Glenn.
When you have extravasation into the disc?
Extravasation into the disc, the only significance that has when you extravasate it into the disc is that it accelerates disc degeneration, causes premature degenerative disc disease. And it also, more importantly, predisposes to adjacent level fracture. The more cement you get into the disc space, the more anteriorly it's located, the greater the risk of adjacent level fracture. This Brian Peterson, M.K. Jesse did a nice paper about this most recently. There are other papers that demonstrate similar things. Same thing. The extravasation into the disc causing premature disc degeneration is not such a big deal because most patients we do this on are not in their 20s and 30s. They don't have Fearman grades 3 through 6. They have modified Fearman scale grade of degeneration 7 or 8, and the scale goes from 1 to 8. So this is very nice cementation. This is done with speed cement. It's quick to dough, working time of about 8 minutes, and it's ready to go right after it's mixed. And so radiofrequency ablation followed by balloon augmentation kyphoplasty, and then the ablation zone is demonstrated to be the shape of the vertebral body within the confines of the vertebral body, and our chicken breast demonstrated this very nicely. So 4 different approaches: transpedicular, parapedicular, extrapedicular, and I'll pause right there to say don't use extra and parapedicular loosely. Parapedicular means around the pedicle, and extrapedicular means outside the pedicle. So this really should be reserved for what I demonstrated to you. There are a couple of other arcane and esoteric approaches, but these are the 3 main approaches, and then the 4th is down the barrel, or gun barrel, or en face view, straight down the pedicle, usually at 20 to 30 degrees of ipsilateral oblique.
Excellent.
Questions, comments?
When we're dealing with more of the maybe mid to upper thoracic, do you prefer a particular approach?
So I like parapedicular approach for the mid to upper thoracic. A lot of times the pedicles are very thin once you get superior to about T10. Sometimes the pedicles are very difficult to access or impossible to access. Parapedicular approach is preferred in the thoracic spine. In the thoracic spine, you go along the costovertebral, costotransverse junction, costotransverse followed by the costovertebral junction. Just over the top of that, that's a path of least resistance into the vertebral body. This is how it should be done. And keep in mind, if people are concerned about perpendicular approach for whatever reason, keep in mind that in adult deformity and pediatric scoliosis surgeries, we put large screws, pedicle screws, perpendicularly in the thoracic spine all the way T10 to the LM, T4 to the LM, T2 to the LM. So this is a very common approach to be used. The perpendicular approach is easier, quicker, and allows you to centralize the tip of the needle adequately to get the balloon in there, or the cement, or whatever device you use to reduce the vertebral fracture.
Excellent.
Did it show like a perpendicular, like a T6?
Yeah, do you have time? I think we have some time. Can we go up to a mid-thoracic level and show that approach?
Sure. You want me to demonstrate at thoracic level?
Sure.
Absolutely. Let's move up a little bit.
Any questions in the meantime?
So here's a nice level. We'll start up and out. And again, on that line, I won't draw it, but ipsilateral superior to contralateral inferior vertebral corner. We'll start here. And so I can feel the rib already. I can feel the back of the rib, and that will keep you out of trouble. And so I will steepen it up, turn the direction of the needle opposite so I can get some bite. And this approach is quite quick. And I'll give myself a little bit of room. The distal tip of the needle, I turned the bevel the opposite way, gave me a few more millimeters. And we'll see before we transgress the medial wall of the pedicle, we'll take a look laterally to make sure we're in the posterior portion of the vertebral body. And again, if we're not, we can make trajectory changes without taking the needle out. If we are, we're good. And so that's about as good of an approach as we can do, as we could hope for. We'll take it into, let's put it kind of in the middle of the vertebral body. All right, and we'll take a look on AP, perpendicular approach of a mid-thoracic vertebral body. And I think we'll be pretty satisfied with the approach. So in this, toward the center, we could use a unilateral approach for unilateral access. We could steepen it up, pull it back, steepen it up here with not quite so shallow of a needle, and put a second needle in, use bilateral. Again, if you're looking for a reduction of vertebral height, a bilateral approach is preferred.
Excellent. I think one thing for the audience to note that if you'll note that Dr. Beall is always starting from sharpening the end plates at the level he's working at. For a lot of you who are just starting out, that's something really to make sure that you're working with the radiology tech to make sure that those end plates are sharpened before.
Arc just a little bit towards you. So we're going to demonstrate the approach. We're going to arc a little bit more right there. All right, this is ideal, right? So we have the end plates that are sharp. We have the pedicles are in the superior one half of the vertebral body, and we have the spinous processes directly midline. This is exactly what we're looking for. This is a direct AP approach. So to line it up takes a little bit of extra time, but it will help you if you get the right approach from the very beginning, the right view. It will help you in the end save time.